As a surgeon, as part and parcel of our preoperative consultation visit, we explain risks that are inherent to any surgical procedure and risks that are specific to those procedures to the patients. One of the more common questions I get is regarding not necessarily the surgical procedure and the antecedent risk associated with it, but expressed concerns about general anesthesia or a MAC anesthetic. And so I asked a friend and an anesthesiologist who works frequently on the group, Dr. Burt Welch, to join me today and to talk about an anesthesiologist's perspective and my perspective as well on anesthesia. By no stretch of the imagination would I want anyone to think that anesthesia was without risk. As a matter of fact, it carries risk in the penultimate form, death. However, in most cases, that's in a patient who's extremely sick or has some underlying mitigating factor. We screen for those things in the history, in the laboratory, and the likes of that. But again, it's very important that one looks at and interprets what Burt and I talk about in this, in the context that we're not saying that it's 100% safe, that it's fail-proof, that nothing could ever go wrong. That would be as far from the truth as I could imagine. And yet, I think it would answer some, or this video should answer some of the questions and allay some of the fears that may be unfounded. Thank you. Hey, social media world, thanks for joining us today. I have a great friend of mine, Burt Welch. He's an anesthesiologist. Burt's actually put me to sleep, and he's taking care of my children, my wife. Great friend, a great anesthesiologist, and he's in the group that provides anesthesia to the Plastic Surgical Center of Mississippi. And we're happy to have them because, one, they're very good anesthesiologists. They oversee some CRNAs here in the center, and they do an excellent job. Our objective here is to get the patient in and out, minimal risk of postoperative nausea and vomiting, good pain control, and then very safe anesthesia. The reason for that is this: one of the most common concerns that patients express to us is not about the surgery or recovery or pain or whatever, but instead, I'm scared to go to sleep. There should be no reason to be scared to go to sleep. You agree with that?
I definitely agree. The statistics show these days that 1 in 250,000, 1 in 300,000 have a severe complication with anesthesia these days. I mean, that's also.
So 1 in a quarter million, all right? We'll take those numbers anytime. Probably safer than driving a car and potentially get killed in a car wreck. Number two is this, and that is the medications. From the time that we were back in our residency in the Stone Age, it seems now, a lot of medications affect your heart, your liver, slow to get out of your bloodstream. The stuff we use now,
it's a lot slower. I mean, it's not like the slow medicines we used to use, our Diprovan that we use, the white propofol, as we call it, gets in your system, out of your system, a lot less nausea and vomiting, and it's quicker to get out. You're a lot more awake afterwards. A lot of our anesthesia gases that we use, these were gases in the old days that stuck around with you forever. A lot shorter acting now. They get out of your system, mostly you breathe them out. And so you're a lot more awake and alert afterwards. If you've got pain control, you're going to get in and get out of here pretty quick.
Yeah, I mean, our objective would be that a patient within an hour and a half of having completed surgery, that they're awake, alert, oriented, and met criteria, and can be discharged home. That's the objective. Speaking of these devices and the gas and agents, monitoring is great now. Okay, blood pressure, pulse rate, and what's the other thing that
you pulse oximetry? That has been crucial to the safety of anesthesia. We're now able to show if you've got an intraoperative problem or a perioperative problem, and that pulse oximetry, which measures the oxygen in your bloodstream, goes down, we can take immediate action to it. In the old days, when we were in school, we didn't have that, and so that has really helped our patients.
All right, and then the other thing is this, and that is really more from a doctor's perspective. Burt and I can relate to this, and anybody else that's in the medical field and working in an operating room can tell you that, it's easy to put them to sleep. The question is, can you wake them up? Okay, that's where the rubber meets the mat. But from the physician's perspective, it's all about being able to put them to sleep. Okay. In the old days, you used a laryngoscope and then a tracheal tube. You had to be able to look down the windpipe, see the vocal cords, and pass this through.
Right.
Okay? That required technical expertise. Tell us about this device.
This is the LMA, a laryngeal mask airway. This was invented, I don't know, probably 10 years ago. And this is something that in the event you cannot get this endotracheal tube down their windpipe, well, like we've done for years and years and years, then we have a device called this LMA for short. Goes at the back of your windpipe there, back of your throat there, lodges there, secures the airway. We can get our anesthesia gas as our oxygen in, carbon dioxide out. It's been a great, it's greatly increased our safety factor in anesthesia. The other is the glide scope. We have a lot more patients, a lot more obesity we see these days, a lot more difficult airways we see these days. This is basically a camera that can, while you're asleep, we can go down into your windpipe and look at your vocal cords. And then by looking at your vocal cord and visually seeing them, we can take this tube, go down through your vocal cords, and know without a shadow of doubt it's in the right place.
And then the other big thing, patients are terrified about being, we hear all the time, oh, I threw my toenails up, for days after I was sick. You take proactive stance in terms of preventing post-operative nausea and vomiting. Tell us what those steps are.
Well, there's usually 4 bases that you can cover with nausea. Of course, there are a lot of people that just does it. One main thing they fear about general anesthesia or surgery is getting sick afterwards. So our Zofran, we use it on our cancer patients forever and ever. We use it in anesthesia forever and ever too. Most patients get some prophylactic Zofran, try to decrease that. That alone helps a ton of these patients. But on top of that, usually we can add some Decadron, we can add some steroids, we can add a scopolamine patch. If you're one of these patients that have problems with riding in a car, get car sickness on a cruise, something like that, you're going to be more prone to have problems. And so we'll probably put a scopolamine patch on you. And the last one is a tried and true Phenergan that we can use. We can give it through your IV, we can give you an intramuscular injection of that. And with those 4, yes, there's probably still going to be a few patients, but it really decreases the amount.
Right. So what you should take from this is this, and that is, great anesthesiologists, great CRNAs, great supervision, and an extremely high level of patient safety. I'm all about that. The last thing I want is an anesthetic complication. I don't want a surgical complication, but I certainly don't look for an anesthetic complication. Yeah. And you would be able to tell us if this patient, when you talk to them either the night before the procedure or in the preoperative area, you would say, time out, Shelby. We need to do this in a hospital setting where we've got an ICU backup, or we don't need to do this until we're, or we can wait until we have laboratory that needs to come back, or they can visit with a cardiologist or a pulmonary doctor or whomever they need to do in order to clear things up. But having said that, I feel very comfortable about the safety of our anesthesia. I hope you do too. If you have any questions, we can always direct you directly to the anesthesiologist. You can visit with them prior to even scheduling surgery. And if you have any questions regarding anesthesia safety, contact Devin or Susan. Thanks.